So the way we will approach this session is by thinking how we can use obesity pharmacotherapy to disrupt the disease of diabetes. And when we say disrupt, that is a bit of a vague term. What we mean by that is a number of things. It's to delay its progression, to improve glycemia, to improve cardiovascular risk factors, and more importantly, prevent the development of the complications of type 2 diabetes that cause suffering to the individual, and they are extremely costly to the healthcare system. These are my disclosures. So the difficulty here is that when we are discussing these medications is that many of them are already used for type 2 diabetes, for the treatment of type 2 diabetes, because they also work on glycemia, amongst other factors. So during this talk, you're going to find that it is very difficult to tease apart the glucose and cardiometabolic lowering effects from the weight loss effects. And that is okay. This is something that we'll have to live with. But we're also getting lots of nice data from medications that do not directly affect glycemia by affecting insulin secretion. And we know, for example, that even good old Orlistat is a medication that can delay the onset of type 2 diabetes, or it can actually improve type 2 diabetes when it is used in people that respond to the medications. I will be spending most of my time on the more recent medications that are available and some that will become available, and discuss the literature around them. So what you're going to see, this is liraglutide 3 milligrams when it is used for people with type 2 diabetes. All of the data that I will be showing you are for obesity pharmacotherapy for people with type 2 diabetes. And you'll see here that people lose, on average, about 6% of their body weight at approximately 1 year after the intervention. You will remember that when Saxenda, which is 3 milligrams of liraglutide, was given in people without diabetes, they lost 8% of their body weight. So it seems that always people with diabetes always lose less weight with whatever obesity intervention we treat them with. And even though many of my colleagues seem to understand why this is happening, I still do not understand why really this happens. So that's Saxenda, and there are also very nice reductions in HbA1c of 1.3%, which is great. Yeah. Okay, so this is another medication that you have got, I believe, in Kuwait. You need to correct me if you don't. Its name in Europe is Mysimba. I think the name locally is Contrave. And what you'll see here in one of the randomized controlled clinical trials, what you'll see are here nice reductions in body weight, which you'll see are very, very similar to what Saxenda does, if not exactly the same, which is exactly what we see in people without obesity. And this is, again, a very nice reduction in HbA1c of about, at 1 year, about 0.6%, which is not too bad. And who knows, maybe the reason why this reduction in HbA1c is not the same as Saxenda may be because liraglutide doesn't just cause weight loss, but it also works on insulin secretion. So maybe we're now trying to dissociate the glucose-lowering effects because of the effects of the drug on insulin versus the weight loss per se itself. So it appears that if the weight is reduced by about 6%, this is truly the HbA1c reduction that people will get without all of the other effects of the medication. Now we're getting into territories of weight loss that we had never seen before. So the revolution in pharmacotherapy for obesity that you can use for diabetes is now happening, and it is a privilege to be part of this. Many of you may remember when you were treating people with diabetes or without diabetes, but with obesity, that we've had Orlistat for 10 years, and that was the only thing we could play with our patients, and it was not a particularly effective medication to take. So these are the study that Carl was referring to. This is semaglutide 2.4 milligrams for diabetes, and that you'll see is that people lose, on average, about 10% of their body weight, people with diabetes. So losing 10% of the weight on average in diabetes now starts becoming seriously important. And I will explain why. I would like to also draw your attention to these figures here, which are the categorical weight losses. And the categorical weight losses matter a lot. These are more than 5% weight loss, more than 10%, more than 15%, and more than 20%. So what you're going to see here is that approximately half your patients are going to lose more than 10% of their body weight. And you will also see that about 1 in 4 will lose more than 15% of their body weight. So let me also, since this is a relatively smaller audience that people can actually shout as well, can I ask you, what do you think is an important cutoff in terms of weight loss for people with diabetes to achieve benefit, okay? You're going to tell me maybe, in fact, I shouldn't say what you might tell me. Why don't you tell me, what do you think is the line in the sand that makes weight loss important, not for everyone, but for people with diabetes? And you can, I don't think we need microphones. You can just shout out loud. How much? 10%. Anyone else? 10%? 5%. Anyone higher? 7. Why are you saying 7? Random, okay, yeah. Why are you saying 5? Yeah, and you're right. And why are you saying 10%? And also, we need people from the back also to tell us what they think. Why are, yes, that's right. Yeah. And you are right that when it comes to glycemia, a 5% weight loss should be enough to cause some improvement. A 10% weight loss, again, for glycemia, which is mostly what you are referring to in terms of diabetes prevention, should be enough. The question is, though, what happens when it comes to more important complications of diabetes? So when it comes to, for example, the more important ones being, say, macrovascular complications, right? So heart disease and stroke. What is your line for that? Is it the same? Now you're confused. The question is, for glycemia, 5% weight loss, 10% weight loss is good, right? It can have an effect. But when it comes to the macrovascular complications of diabetes, what percentage weight loss is necessary to improve those? How much? How much? We need a number. Okay, so I really like hearing your opinions. That's great to hear. So, and it is very difficult to put a number to this because we do not have a number for, remember now, obesity and weight loss reduction in HbA1c to translate to macro and macrovascular complications. We just don't have those data. The data that we have are, for example, we know that when you give semaglutide 1 milligram, i.e. Ozempic, for type 2 diabetes, for people who have heart disease, they lose, this is the medication that can actually reduce their cardiovascular events, right? The same for liraglutide 1.8 milligrams, the same for SGLT2 inhibitors, right? So the question now is, what about weight loss in order to achieve the same benefit? And that is the problem. We don't have the data. So what we have to do is to borrow the data or try to extrapolate from studies that have not used medication. And remember, the two studies or the two principles of treatments I always remember are, number one, the look-ahead randomized controlled clinical trial. And the look-ahead, they use predominantly behavioral therapies to reduce weight. And what they found is that the mean weight loss was 8%, okay? And with an 8% mean weight loss, there was no difference in cardiovascular events. So everyone was a bit disappointed when that trial came out. But then a subsequent subgroup analysis of that trial showed that for those people that lost more than 10% of their body weight with lifestyle interventions, these were the people that actually reduced their incidence of heart attacks and stroke. So 10% starts being now an important number. And you're going to see here that, who knows, about half of your patients with semaglutide that managed to achieve that should be able, hopefully, we're now extrapolating, to achieve reductions in their macrovascular events. We also have got data from bariatric surgery, which is even more dirty in a way, because then you have got many mechanisms that are in place: insulin secretion, insulin sensitivity, and so on. And it appears in those trials that you need about 15% or so weight loss, at least 10, of course, but even 15% weight loss in order to have improvements in macrovascular events. And here we have got 1 in 3 people managing to achieve that. So the reason why I'm having this discussion with you is because it is important to understand and to tailor the treatment to the patient sitting in front of us and what we're trying to achieve. When it comes to 5% weight loss, as we just heard, this may be enough for glucose reduction, but it may not be enough in order to prevent the really important events that make our patients suffer and actually kill some of our patients. And here is, again, perhaps a little bit of a change in the way that we are going with these medications. We're not only seeing important HbA1c reductions, but we're seeing here, you're going to see physical well-being and physical functioning, and this is with the higher doses of the medications. And physical functioning is a relatively resistant problem with diabetes and obesity. You need significant weight loss in order to achieve that. And we know that from bariatric surgery that people need to lose a lot of weight in order to improve this complication of their obesity and diabetes. And this is now what we are seeing with the pharmacotherapy for obesity that is becoming more in terms of efficacy to what bariatric surgery can achieve. And that is why we're so excited about this. And now we're moving to extraordinary effects. We're moving to the use of the medication that you will soon get, and I'm very jealous about that. You're going to get tirzepatide, and these are the data for diabetes, and you will remember that tirzepatide is a combination of 2 hormones, of GLP-1 and GIP. Again, the data in diabetes will be difficult to dissociate even more because we know that these hormones are the 2 incretin hormones that increase insulin secretion. So it is not unsurprising that you are seeing very, very major reductions in HbA1c. I mean, 2.3% from a starting of about 8% It's something we have not been able to achieve before. And if we did achieve it, it would have been with insulin, which would have caused a number of problems with hypoglycemia and weight gain. And here, I don't know if you can see in this graph, you're going to see a reduction of HbA1c of 5.8, down to 5.8, apologies. And let me move to the next slide, which is even more impressive, which is the weight loss. And you're going to see a 12.4 kilogram or 13% mean weight loss. Mean weight loss. And it is always important to remember these are mean weight losses, because we always have people who respond very well and people who respond less well. And you'll see from this slide here that if we agree that 10 and 15% approximately are the cutoffs that we are trying to achieve, not only for glycemia, but for other effects, you will see now that half of your patients, more than half, will lose more than 10% of their body weight. So we are hoping that these are the people that, at least if they have established cardiovascular disease or high risk factors for cardiovascular disease, they will benefit from reductions in their morbidity and mortality. If these amounts of weight loss are important to prevent people from developing cardiovascular disease as primary prevention, that is very unclear. And maybe they will not, but maybe these are effects that will be important specifically in people with disease. In the last few minutes, let's talk a little bit about some interesting new molecules. We have got the combination of GLP-1 with glucagon. And you remember glucagon has been traditionally bad for diabetes because it would increase blood sugar, so therefore we were reluctant to use it. But it seems that at low concentrations of glucagon, that can have a positive effect on energy expenditure. So by using a combination of GLP-1 and glucagon, you decrease food intake because people feel more full and less hungry, and you increase energy expenditure as well. And these are some of the data, some of the best data that I could find from a double-blinded randomized controlled clinical trial of this molecule that combines the two. This is called cotachutide, and this is compared with liraglutide in this RCT for people with diabetes. And what you'll see, I know these are small graphs to read, but you're seeing reductions in HbA1c of about 1.2%, which are not that bad, and you're seeing weight loss of about 5%, which is not that bad. I must say to you that the results of these studies are not as exciting or encouraging as we were expecting, but they are still there, and it may be the case that the role of these medications may be more in people who have got type 2 diabetes and fatty liver disease or NASH as compared to type 2 diabetes and obesity. So you see how now we're going to have more toys to play with, and we can then personalize them to the person in front of us depending on what's wrong with them. And another hormone, this is just of the last few slides that I have, another hormone that we had forgotten a bit in diabetes, I had forgotten it for sure, is amylin. And amylin is a hormone that's also produced from the pancreas, and it has got effects on reducing food intake and on improving blood glucose. But I never had the privilege of using pramlintide, which has been used in the States for diabetes. And now what we're seeing is with this analog of amylin made by Novo Nordisk, and it is a weekly analog in this phase 2 study, only at 6 months, people had lost about 11% of their body weight. And who knows, you can make predictions that this weight loss, this is of course in people without diabetes, so be careful there, that this weight loss at 1 year may be almost the same as semaglutide. So again, another agent to use for weight loss. And therefore, it comes as no surprise that if you combine these two very effective medications, cagrilintide with semaglutide in this phase 2 study, people do extremely well. And again, these are people without diabetes. The data with diabetes will come. But people lost, within 4 months of treatment, they lost 17% of their body weight. So the combination of cagrilintide and semaglutide is at the moment considered to probably be the most powerful medication we have soon available, I would say, or in relative terms, the most powerful medications we have on the planet to treat obesity, with a predicted weight loss at 1 year of 27%. Not excess body weight, total body weight loss. Now we are in the territory of bariatric surgery with 1 injection per week. I'm not saying it's the same as bariatric surgery. It will have other issues. So here is a nice slide that I think focuses our minds, and it shows some of the things that we have just been discussing, that in terms of obesity in general, you need to treat the person sitting in front of you. And as you have said, 5% weight loss will be enough to prevent someone from developing diabetes if they have got pre-diabetes. But if you have got someone who wants, for example, to achieve diabetes remission, type 2 remission, or if you've got someone with type 2 diabetes and heart failure, so difficult now complications of diabetes, you need a lot more weight loss in order to improve their specific complications. Now, I'm going to say that I should probably come to an end, and I would like to say that these are some of the mechanisms that you can use, that weight loss that uses in order to improve not only glycemia, but who knows, cardiovascular disease as well. We don't know yet, but we are hoping that this is what will happen. But I wanted to finish with this slide as well. The only reason we are now talking about weight loss in diabetes is because we can achieve it with medications. Okay? Let's be honest and frank about that. For the last 40 or 60 years that bariatric surgery has been able to do the same, we have been ignoring it because it's an operation, and we traditionally don't like operations. So surgeons are not very happy about this. That's fine. And Geltrude will tell us a lot about surgery and the amazing effects of surgery at the moment. So and up to recently, we have actually been talking about the non-weight loss effects of our wonderful medications, only because we couldn't achieve enough weight loss. So just because we are using weight loss now as a modality of treatment doesn't mean we should forget all of the other non-weight loss tools we have in our possession. And SGLT2 inhibitors are a perfect example of those tools, where you achieve negligible weight loss, negligible changes in lipids. In fact, probably some of them are contrary to what we would like, and yet you see major improvements in cardiovascular events. And that's why, and kidney events as well. So just not macro, but microvascular complications. So it is now the combination of weight loss with non-weight loss mechanisms that is probably the next step in this field. So to finish off, we finally have got safe and effective medications for obesity. And I think that it is very unlikely that we're going to see that in the long run, these obesity medications are going to have new safety signals. We need to see, but I doubt it. And indirect evidence, that's what the important word here, indirect evidence tells us that 10 to 15% weight loss is the amount that we need to achieve in diabetes to have not just glycemic outcomes, but meaningful outcomes in terms of morbidity, mortality, and actually probably quality of life. So the hope is that our obesity pharmacotherapy would translate to these reductions in complications, but we need to do the studies. We need to find out what obesity does in type 2, what obesity interventions do for type 2 diabetes. And I really want to stress the importance of combining our weight loss with our non-weight loss interventions. Thank you for listening.